Yes, sir. I will be giving the introduction, sir. A warm evening to all. On behalf of Indian Medical Association, Medical Students Network of Tamil Nadu, I take great honor in welcoming a speaker for today's clinical discussion on cerebrovascular disease, stroke, Dr. V. Nagaraajan, sir. Good evening, sir. Dr. Nagaraajan, sir, is currently the Professor Emeritus and Distinguished Professor at Tamil Nadu Dr. MGR Medical University in Chennai. He is Chairman, National Neuroscience Research and Task Force, ICMR, and also the Chairman, IEC, at Madurai Medical College, Madurai. He is also the former Chairman for selecting the directors of NIPERS all over India. He is also the neurologist to His Excellency, Governor of Tamil Nadu. Besides being the member advisor, PhD committee at Government Tamil Nadu University, he is advisor at Shiksha O Anusandan University, Chhattisgarh, and a member in Academic Council, NIMHANS, Government of India, Bengaluru. He is a visiting professor at the University Medical School, University of Tokyo, Japan. He is a recipient of various national and international awards, including the Distinguished Nicole Award in Japan for his work on vascular dementia. I once again welcome you, sir, to enlighten and inspire us in this clinical discussion on cerebrovascular disease, which will be presented by Mr. Prashant, final year student from Madras Medical College and National Joint Secretary, Ima Msn. Over to you, sir.
Good evening, sir. Good evening, ladies and gentlemen, to all our viewers out there. So this is Prashant, final year MBBS from Madras Medical College and the National Joint Secretary of Ima Msn. So I'll be presenting a clinical case today to Dr. Nagaraajan, sir, and we'll have a discussion with under sir's leadership. So, sir, can I start with the case?
My best wishes to you. Carry on.
Thank you, sir. Kiran, can you start sharing the PPT? Okay, so Mr. ABC, a 62-year-old male, a mill worker by occupation from Karapakam, Chennai, with education status of class 8 being passed and a monthly income of rupees 20,000 and the lower middle class scale according to BG Prasad classification. And the right-handed gentleman came to the hospital with chief complaints of. Can you change to the next slide?
Razan, sorry for the interruption.
Yes, sir.
Importance of handedness.
Sir, the present patient is a right-handed gentleman. Generally, it is the case that for a right-handed person, the dominant lobe can be identified using the handedness. And in case of right-handedness, it might be the more so the left. And if it is a left-handed gentleman, around 70% of the individuals will still have a left dominant lobe, and the rest 30% might have a right dominant lobe. So it will be easy to localize the lesion using the handedness.
What is the type of speech disorder you get in a right-handed paralysis?
Sir, he might get if the dominant lobe is involved, he might get aphasia, sir.
Dominant. We are very careful to answer it is dominant lobe because it can be a right or left. Okay. 90%
Yes, sir.
of people do have dominant hemisphere on the left side. And only I can tell you that the handedness do decide the dominance, number one. Number two, 90% of right-handed people, they do have the speech center on the left side. And in the 10% of rest of the people, if you have a left-handed people, still 5% of them do have speech center on the left side. Still it is on the left side. And very rare, only 5% of people have got on the right side. Can you mention the name of the speech center on the left side? What is the area called?
Sir, the Broca's area and the Vernix area.
Broca's area. So keep it in the mind about this discussion. And when you come back to the case discussion, I will give importance of what type of speech disturbance you do have when the dominant hemisphere is involved. If I forget, you remind me. Okay,
Sure, sir.
carry on.
Next slide, Kiran. Yeah. With chief complaints of weakness of the left upper limb and left lower limb since 4 days, slurred speech since 4 days, and deviation of angle of mouth to the right since 4 days. Next slide. History of presenting illness. The patient was apparently normal before 4 days, with a right-handed gentleman appearing normal in his usual state of health, performing routine daily activities until the current illness, presence with weakness in the left upper and lower limbs since 4 days. So the patient went to sleep at 11 p.m. the previous night of developing illness. On awakening at 5 a.m., he experienced a weakness of the left upper limb, sudden in onset, not associated with pain, followed by weakness in the left lower limb within the next 1 hour, sudden in onset, not associated with pain. He
No,
also complains of slurring.
1 minute was
Yes, sir.
introduction. I will discuss right now. You said pain. Pain where? Not
Sir, not associated with pain on the limb, sir.
is in the head or in the limb.
Limb, sir.
Limb.
Yes, sir. With movement, we're trying to move the limb.
Observe that pain is in the limb. Okay. Not
Yes,
associated
sir.
with the pain in the limb. Do you have anything to say for that?
Uh, sir, like,
What is the importance of your statement?
um,
I'll tell you.
that is,
I'll tell you.
yes,
Suppose
sir.
somebody has got a brachial plexopathy or a spinal cord lesion, which involves, say, for example, that somebody can have a transverse spinal. Let us forget about it. That this is hemiplegia. Don't commit yourself now anything at all. We are analyzing the history. Am I correct? So if
Yes,
somebody
sir.
has developed pain and weakness, it is lesion is peripheral. Understand? It is not
Yes, sir.
it is not central, and maybe in the spinal cord or somewhere in the plexus. So pain association in a cortical lesion is unusual. So now later on when we discuss where is the lesion, this particular point will help you to decide where is the lesion. Okay. Now let us forget about CT scan, let us forget about X-ray, let us forget about everything. Now purely clinical.
Yes, sir.
Okay, don't forget, don't talk anything about the investigation now at this stage. So carry on. He also complains of slurring of speech.
Since 4 days, sudden in onset, associated with drooling of saliva and deviation of angle of mouth towards the right side, while speaking, eating, and showing teeth. He was then brought directly to our hospital at 2 p.m. after 4 days of onset. Next slide. History of difficulty in lifting the left arm above shoulder, buttoning the shirt, holding glass, using left hand for toilet purposes.
At this stage,
Difficulty.
I want one explanation from you. You
Yes,
said
sir.
slurring, very easy. Slurring. What is mean by
Yes, sir.
what is it?
Um,
Slurring.
Sir, slurred speech can be because of aphasia or because of dysarthria, sir, wherein the patient is not able to pronounce the word very clearly. It could be because of labial dysarthria or a lingual dysarthria, sir.
When you commit yourself slurring, what do you want to convey?
Uh, so that there is not a very clear speech.
Trick of the examination. You have to lead the examiner to your diagnosis. Clear?
Yes, sir.
You have to lead the examiner towards diagnosis. I'll tell you a trick of the trade. Never commit anything more than that. Never ask him, give him an opportunity to ask you a question. It is difficult to answer for you.
Yes, sir.
So, slurring is a word. It has got a connotate, a distinct meaning. Instead of that, you always say Sir, he had difficulty to pronounce words.
Sure, sir.
Difficulty to pronounce words because if somebody has got a facial palsy, he may have difficulty to pronounce words. Say, for example, there are labials, there are linguals, there are so many type of words at the day. So labial words will be problematic. Say, for example, I say papa, I use my lips, papa, okay. So how we have a fellow with hemiplegia who is presenting with a facial weakness may say fa fa, fa fa. Are you able to get the point? Fa fa.
Yes,
Instead
sir.
of pa, they use fa fa. So regarding the various speech disorder, I'll let you know. Huh?
Sir. Yes, sir.
So patient had difficulty in pronouncing the words. That's the most appropriate commitment rather than telling that he has got a slurring. Slurring is a distinct problem due to cerebellar or peripheral or some other issue. You are localizing, you are inviting trouble by yourself. So you should not say patient has a difficulty. Let him ask again what type of difficulty. Then you explain, sir, I asked him to pronounce few words. He is not able to pronounce. I asked him to pronounce papa and he said fa fa. So that is the difficulty he has got. So that is a commitment you should have and don't dig grave for yourself. Most of the students, they don't understand that they are pulling themselves into the well. So if you use inappropriate word and inappropriate description, the examiners are so happy to, intelligent examiners, otherwise they may not carry on. So, but don't use such a word and say that patient has difficulty in pronouncing the words.
Yes, sir.
What the importance later. Okay. Right now
Sure,
is
sir.
difficulty in lifting arm. Now you go ahead. History of difficulty
Yes,
in
sir. History of difficulty in lifting the left arm above the shoulder, buttoning shirt, holding glass, using left hand for toilet purposes. Difficulty to stand from the sitting position, buckling of left knee, to hold slipper between toes in the left leg. No similar history noted in the right upper or lower limb. History of deviation of angle of mouth to the right side and drooling of saliva on left side. No history of involuntary movements before or after the event. No difficulty in closing his eyes. No dryness of eyes or loss of taste. Next slide.
no, wait a minute, wait a minute.
Yes, sir.
Difficulty in closing her eyes.
His eyes, sir. Sorry. Grammatical error, sir.
It's a male or a female.
Sir, male, sir. His.
You're all very careful. Huh? I noticed it immediately. And what is the importance of telling no dryness of eyes, loss of taste?
Uh, Sir, depending on the involvement of the cranial nerves, if there is an involvement of the seventh cranial nerve, the anterior two-thirds of the tongue might lose sensation, sir, because it's supplied by the chorda tympani branch. And similarly, the facial nerve supplies the lacrimal gland as well. So there can be a dryness of eyes associated. So history of dryness of eyes and loss of taste, sir.
What in this context? Dryness of eyes?
And again, in seventh nerve palsy as well, they'll not, if it's a lower motor neuron palsy, they'll not be able to close the eyes. So that will also cause dryness.
So that gives a clue to you that this is not a lower motor neuron lesion. Am I
Yes,
correct?
sir. Yes, sir.
Question back to you. Can that be a lower motor neuron lesion and difficulty in using limbs?
Yes, sir. There can be a lower motor neuron lesion with difficulty in using limbs.
Okay, what
Uh,
what could it be?
Sir, in the initial phase of spinal shock, the patient will have
So,
atonia, sir.
I'm not talking spinal shock means spinal cord. Okay, you are
Yes,
talking
sir.
about a brain lesion. You are talking about a brain lesion. You should not use the word spinal shock.
Yes,
Hmm?
sir.
The point. Suppose
Yes,
I
sir.
So if the lesion is in the pons,
Yes, sir.
involving the lower motor neuron of the seventh nerve, and then
Yes, sir.
hemiplegia will be on the opposite side. That is called Millard-Gubler syndrome.
Gubler syndrome.
Okay, so there can
Yes,
be a
sir.
motor neuron lesion with a crossed hemiplegia. You must, when the question is asked back, you answer this. Otherwise, don't commit yourself.
Fine, sir.
Okay, these
Sure,
are
sir.
tips for examination. Uh,
Yes, sir.
if they ask question, don't be over smart and try to commit yourself. But the smartness has to be expressed when you wanted it.
Sure, sir.
So when you say, particularly say no dryness of eyes in the face, why you should tell it. The answer from your side should be, sir, there are situations wherein the lesion can be in the pons. I do not know now. In that case, there will be involvement of lower cranial nerves. Lower cranial nerves. Don't say seventh nerve. Lower
Yes,
cranial nerves and lower motor neuron. And also there may be a taste loss also may be association. Always use may. Okay. You should be very ambiguous in your statement when you are discussing about the history.
yes, sir.
Very ambiguous. You should not be very definite because you do not know at this stage where is the solution. Get the
Yes,
point?
sir.
So you
Yes,
always
sir.
ambiguous statement, not a confirmed statement. For example, you said spinal shock. Spinal shock is a confirmed statement. Then I will say that
Yes,
this
sir.
is the spinal cord. Clear?
Yes, sir.
Was very
Sure,
careful
sir.
in answering the question. Go slow, steady, and learn the mode of examination. The examiner mode. First of all, judge all the four examiners about you, and then who is very active. One will be very active. Other three will be listening. Okay, I am telling a secret. Three of them doesn't want to ask you question, but one will be keep on asking question. That is a combination. So you must know that you must assess the group of examiners who is a troublesome fellow. Okay, right. Carry on.
Yes, sir.
Next slide.
Next slide, Kiran.
Next slide.
Kiran, are you there?
Carry on.
Yes, sir. No abnormalities in perception of smell, no difficulty in vision and perception of color vision, no history of diplopia, ptosis, no abnormalities in perception of different modalities of sensation in
In the
the face.
in the
Yes,
current
sir.
state, no abnormalities in the perception of smell becomes very important because we see a lot of cerebral vascular lesion with corona. So
Yes,
corona
sir.
early smell loss is there. So this is the latest addition of clinical history is very important.
Yes, sir. Sir, shall I proceed, sir?
Please carry on.
No abnormalities in perception of different modalities of sensation in the face and forehead, and no difficulty in chewing. No impaired hearing, vertigo, or tinnitus. No difficulty in swallowing, nasal regurgitation, or nasal tone of voice. No difficulty in lifting head off pillow and turning side to side. No difficulty in forming bolus and pushing food into the back of mouth. Informant mentions that there is no history of altered consciousness
Say
or memory dysfunction.
1 minute. You should say that
Yes, sir.
no difficulty in swallowing. Don't try to tell all these things. No difficulty in forming bolas, pushing food into the back of the mouth and all unwanted terms. We say no difficulty in chewing and swallowing. That's the
Sure,
word
sir.
use it. Huh?
Yes, sir.
difficulty in chewing and swallowing, both solids and liquids, very important.
Yes, sir.
Solids and liquids, and more difficulty in swallowing hot or cold liquid. For example, I'll tell you, in myasthenia gravis, people will not be able to swallow hot liquid, but they will be able to swallow cold liquid. So that is very important to tell that these people has got no difficulty in chewing, no difficulty in swallowing food. There is no history of nasal regurgitation. Very important, because nasal regurgitation is one of the important signs of lower cranial nerve. To tell you the act of swallowing, that, that chews, the tongue pushes the chewing to either side properly without itself got grinded in the teeth, and then keep on chewing. And then what happened? There are three phases of swallowing. One is called buccal space, that is oral phase. So in the oral phase, all the food is chewed well, and then it reaches the posterior lingual side, that is pharyngeal stage. When at pharyngeal stage, what happens? The tongue flows back, the pharynx contracts and squeezes the food to the esophagus. And this food flows through epiglottis, closes the epiglottis, and then enters through the esophagus. Once it enters the esophagus, it's involuntary. Till then, it is voluntary. And one important thing happening is how it is pushed to the esophagus. All the spaces are closed. One space which is closed is the mouth. Another space which is closed is the trachea. The third space is the nasopharyngeal area, and that is closed by a soft palate, which is acted by lower cranial. So if the lower cranial nerves do not act, there will be a reflux into the nasopharyngeal area, and patient will try to regurgitate the food through nose. So that is the importance of the. So there are three phases of swallowing. One is called oral phase, second is pharyngeal phase, third is the esophageal phase. The esophageal phase,
Yes.
once it enters, it becomes automatic and it is getting pushed like this, down to the stomach. So the lower end of cardia is very tight, and as it reaches down, the lower end of cardia, esophagus cardia will open and it will enter the stomach. Food will enter the stomach. So it closes. So very important to say that there is no nasal regurgitation. Just to rule out there is no cranial nerve involvement. But I'll tell you something. Initial phase of any upper motor neuron lesion may have a transitory lower motor neuron lesions. That may be there for a couple of days, that's all. It will disappear immediately. Transitory urinary retention, it will disappear within a couple of days. So there may be probably, that is what you mean by spinal shock. It is not spinal shock, it is called neural shock.
Yes,
Neural
sir.
shock. Okay. Spinal means you are localizing the lesion. Neural shock can be anything else. So
Yes, sir.
acute difficulty in speaking, acute difficulty in swallowing may be present in many cases of upper motor neuron lesion. So it is quite possible to have it like that. You carry on
Yes,
now.
sir. Sure, sir.
No abnormality.
Informant. Yes, sir.
No abnormality.
Sir,
Start from there.
this has been done, sir. Informant mentions that there is no history of altered consciousness or memory dysfunction. Next slide. Patient apparently oriented, understands and responds with words, able to experience pain of mosquito bite and temperature differences, able to feel the cloth and bed, no history of bladder.
Okay. If there are
Yes,
no
sir.
mosquitoes, what will you do then? How do you know it? If there are no mosquitoes, so patient is able
Sir,
to feel the pain. That's all.
yes, sir.
The pain, huh?
No history of bladder or bowel dysfunction or palpitation or abnormal sweating. No history of fever or headache, nausea or vomiting. No history of trauma. Shall I go to the next slide, sir?
History of trauma to the head or spine.
Yes, sir.
You must trauma means suppose somebody has got a small trauma in the lower limb, that doesn't orient ourselves, you know. So
Yes,
you
sir.
must have your orientations, no trauma to the head or to the spine.
Yes, sir.
Then
Next slide. Past history. No history of similar complaints in the past. A known hypertensive since 5 years and on treatment. Amlodipine 5 mg twice a day and metronidazole 2.5 mg once a day with poor adherence.
wait,
No
wait,
history of,
wait.
sir.
No history of similar complaints in the past. What is the importance of your statement?
Um, Sir, similar complaints for a particular duration, such as transient ischemic attack or a reversible ischemic neurological deficit, these two can happen and increase the risk for future strokes. So these happen for a duration of less than 24 hours in case of transient ischemic attack with no evidence of infarct radiologically, sir. Whereas in reversible ischemic neurological deficit, there is no
Don't talk about
radiological component.
don't talk about radiological impact. Your answer is correct because TIA is what is called transient ischemic attack. Normally precedes a permanent attack. Okay. Suppose somebody has got about 2 or 3 episodes of transient ischemic attack. How do you know it is transient ischemic attack? Tell me. How do
Um,
you know the history of a transient ischemic attack?
Similar symptoms less than 1 hour, sir.
I'll tell you. For that, you should know what is the transient ischemic attack. What are not transient ischemic attack? Are you listening?
Yes, sir.
Now, what is the transient ischemic attack? Number one is transient difficulty in using limb. It lasts for a few seconds to a few minutes and then returning normally. So you will go to a private practitioner, get a big complex injection, and come. Suppose that is what I want to create a good graduate that you should recognize this is TIA. Okay. Number two, transient speech arrest. Somebody may say that suddenly I was not able to speak for some time, and then I am able to speak in about 5 minutes. I took a glass of water, I am all right, sir. So they will try to impress you that it is not a big disease for them at all. Third thing is transient loss of vision. I emphasize the point because transient monoocular blindness is seldom recognized by patients. When they will recognize while taking bath, suppose some soap comes in the ear, in the eye, they try to put you on the smoke, where the soap is gone. Suddenly they say no vision at all. Even then they will not understand, they will not have no vision on the eye. So monoocular visual loss is seldom identified by the patient. Suppose if both eyes are blind, they will recognize immediately. Monocular vision is for stereoscopy only. I mean, the binocular vision. Monoocular vision is sufficient for a vision. Clear? So, transient loss of monoocular vision, number one. And then thirdly, transient difficulty in walking. Transient difficulty in walking. Somebody may keep walking, suddenly they will feel something difficult for them to walk and all. So these are all common symptoms. There are many, but due to time, I am restricting. You should know what is not TAA. Not TAA list is number one is syncope.
Yes, sir.
Suddenly somebody loses their consciousness. It is not TIA. Transient blurring of vision, not TAA. Transient speech difficulty, not arrest. Dysarthria, not TAA. And transient weakness of the body is not TIA. So syncope is not TIA. Transient loss of consciousness is not TIA. It's a brainstem lesion. Okay, these are very is it that to know which are not TIA. TIAs are always focal. You understand what I mean by focal? Either to the
Yes,
right
sir.
or to the left. They are not generalized. If you have this concept in mind, you'll be able to understand what is not TIA. Okay, now we go ahead.
Yes,
Not
sir.
expensive.
Not a known case of diabetes mellitus, bronchial asthma, chronic obstructive pulmonary disease, tuberculosis, ischemic heart disease, rheumatic heart disease, infective endocarditis, arrhythmias, renal disease, or bleeding or clotting diathesis, epileptic disorder, migraine, lipid disorders, or peripheral vascular disease. No history of prior surgeries or admissions in the past. Next slide. Drug history. On medication for hypertension, amlodipine 5 mg twice a day, metalazone 2.5 mg once a day, since 5 years with poor compliance. No history of use of anticoagulants for any cause. No history of use of alternate medicines or medicines without prescription. Next slide. Personal history. Non-vegetarian and has a normal appetite. Perform daily course without assistance before the current episode. Sleep undisturbed. History of smoking BDs since 30 years. 12 BDs a day with 1.8 pack years. History of ethanol consumption, brandy since 20 years, 90 ml per day, giving to 54 grams of alcohol per day. No history of IV drug abuse or substance abuse. No abnormal sexual behavior. Next slide.
No.
His brother was a hypertensive and died of myocardial infarction 5 years ago at the age of 63 years. This corresponds to the family history.
Wait a
Yes,
minute.
sir?
Instead of saying no abnormal sexual behavior, there is no extramarital contact. And there are no history suggesting of any sexual
Sir, sorry, sir, your voice is a bit feeble, sir.
no history of extramarital sex contact, clear, and then no history suggestive of any venereal diseases.
Yes, sir.
Okay, carry on.
Sure, sir. Next slide. Family history. His brother was a hypertensive and died of myocardial infarction 5 years ago at the age of 63 years. Next slide. Summary. This 62-year-old elderly gentleman, a chronic smoker, alcoholic, and hypertensive on irregular treatment, presented with acute onset cerebrovascular disease of weakness of left upper and lower limb, associated with weakness of left lower half of face, and slurring of speech of 4 days duration, currently non-progressive. He does not have any symptoms suggesting involvement of higher mental functions, brainstem, cerebellum, sensory system, bowel or bladder. I consider him to be having left-sided hemiparesis due to completed stroke involving the right middle cerebral artery territory, probably due to thrombotic infarction in the static phase with cranial nerve involvement. Shall I continue, sir?
The last one
Yes, sir.
is not to be informed now.
Yes, sir.
You always in examination only those 2 points, first 2 points you should go. Okay.
Yes, sir.
Examiner will ask you, okay, what do you think it is?
Yes, sir.
You should answer these questions. If you
Sure,
come
sir.
yourself earlier, they will go for the second wrong question to you to clamp you.
Yes, sir.
You should not tell at this time. You tell the summary and keep quiet for some time. Then let the examiner ask, okay, what do you think it is?
Yes,
Then
sir.
this answer should come.
Sure,
Or
sir.
ask what is the diagnosis? You tell these words. Otherwise, you should not tell.
Yes,
Okay,
sir.
till then, And then if you said, what is your diagnosis? The diagnosis, you should say that, sir, it is a left-sided hemiparesis. Let him ask more questions. Don't
Yes,
come in
sir.
fully. Okay.
Sure, sir.
Is there any other question is there? Any
Uh,
other is there? Any other slide?
yes, sir. We have the examination, sir.
Okay, carry on. So
Yes,
this is
sir.
provisional diagnosis.
Yes, sir.
At this stage, you should not say involving metacerebral artery, etc., etc.
Yes, sir.
You say that, sir, probably this is a cortical lesion. Probably this is a cortical lesion. Okay. How do you
Yes,
know
sir.
metacerebral artery? How do you know it is? These are all unwanted commitments.
Yes, sir.
Always in examination, in a presenting, humble presentation, in a Hanuman posture, and see that you get out of the examination without any trouble. Clear? So
Yes,
don't be
sir.
smart in telling something and get into trouble.
Yes, sir.
That is the way, the trick of the examination is step by step, committing the examiner to ask you more questions and then get out. Okay? Please carry on. On examination,
Yes, sir. The patient was examined in a well-lit room upon consent on the 10th of October. An elderly male lying down, supine comfortably on his bed. Limb attitude appeared normal. Patient conscious, cooperative, and well-oriented to time, place, and person. Moderately built and nourished. Weight of 55 kilograms with a height of 160 centimeters with BMI of 21.5 kilogram per meter square. Next slide. Vitals. Pulse 74 beats per minute. Regular in rhythm. Normal volume. Normal character. Arterial wall is not thickened. Peripheral pulses are felt with normal intensity bilaterally. There is no radioradial delay or radiofemoral delay. Blood pressure 1. Yes, sir.
okay. What is the importance of examining the pulse?
Sir, the pulse, if it is an irregularly irregular rhythm, then probably it could attribute to atrial fibrillation, sir. So this atrial fibrillation has a higher propensity to cause emboli that might get lodged, a thrombi that might get lodged in the cerebral vessels and form an emboli, sir. So that might precipitate a stroke.
What are the causes of irregular pulse?
Um, so irregularly irregular will be there in atrial fibrillation.
Atrial fibrillation.
Yes, sir.
Second is multiple ectopics.
Yes, sir.
How do you differentiate these two? The point is, atrial fibrillation is irregularly irregular.
Yes, sir.
Okay.
And irregularly regular is
Ectopics are regularly irregular. Ectopics may be couplets, triplets, or it may be scanty. And you do not
yes,
know when
sir.
it occurs also. Clear?
Yes, sir.
The next question is coming to you is recording the blood pressure if a
Yes, sir.
person has got atrial fibrillation. What are the method? You said 160/90 measured in the right upper limb position, and now
Yes,
suppose if you have fibrillation, how do you record the blood pressure?
sir, we record the blood pressure thrice and take the average, sir.
You take the blood pressure 3 times and take the average of it. Huh? Okay, that's correct. That's correct. Correct. Carry on.
Um, respiratory rate 18 cycles per minute, predominantly abdominothoracic, depth is normal, no use of accessory muscles for respiration. Axillary temperature of 37.3 degrees centigrade. The jugular venous pulse is normal. Next slide.
JVP, how do you examine?
Um, sir, like we ask the patient to lie supine, sir, at 45 degrees using a scale. Um,
What is the concept of it? Any idea?
sir,
What is the concept of making him to lie on 45 degrees? Okay, now I'll tell you. This is
yes, sir.
making the JVP to be in line with the cardiac pressure. You are making both the levels equal. Left atrium, you know what is normally the right atrium has got the equality to the JVP. It has got a right atrium, you know. Right atrial level should be there. Any pressure should be there. Even BP should be recorded at the level of the heart. You cannot keep on one table down and then measure the BP. It should be at the level of the heart. So any pressure is corresponding to the height of the organ. Therefore, by making it 45 degree, you are keeping the JVP in line with the left atrial, right atrial level. So that is the purpose for which you keep them on the right atrial level. That is what the 45 degree. If you examine a normal person, JVP be elevated in a normal person, if you make him lie down, straight lie down, prone. So the 45 degree is very important because you are standardizing your test. So if somebody has got a 45 degree angle, JVP is elevated, it is full. That shows that this man has got an impending right atrial failure. Clear? Okay,
Yes,
now
sir.
you see 1 inch above the clavicle. Normally 1 inch above the clavicle. It is the external jugulars are not well seen when the pressure is low. But if the external jugulars are very prominently seen, that means this person has got a right atrial high pressure, right ventricular high pressure, something like that, you know. You should be very careful in that. Okay,
Yes,
please
sir.
carry on. Carry on. JVP normal. Next.
Head-to-toe examination. There is no evidence of pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, fetal edema.
What is
No resting night time.
what is clubbing?
Sir, because there is a hypoxia, um,
No,
there is
what
a
define,
secrete.
define clubbing? Oblication of the angle between nail and nail bed.
Okay,
Oblication
sir.
angle between the nail and the nail bed. Suppose I show my nail, there is an angle there. You know, see the angle there. You can see yourself.
Yes, sir.
Angle. This angle is lost if the nail bed is raised. So it becomes an arch like this. Clear? It becomes an arch like this.
Yes, sir.
Nail and nail bed, it is due to subungual proliferation of tissues. Why there is a subungual proliferation of tissues? Because of chronic hypoxia. Chronic hypoxia is a feature of cyanosis. Chronic hypoxia is a feature of chronic insufficiency of the peripheral blood. In chronic lung disorders, it is very common. There are different.
Yes, sir.
Can you get clubbing in one limb, one finger alone? It is possible.
No, sir.
No, it is possible.
Okay.
In situation, in congenital condition, clubbing can be congenital, it can be acquired. In congenital, one particular finger alone can be enlarged. Sometimes neurofibroma can be there underneath the nail and can cause clubbing like picture, a clubbing like picture. So clubbing is very important. It should be present bilaterally. But in many other conditions, sometimes it develops in unilaterally and then go to the other side. So clubbing and cyanosis denotes heart disease. Clubbing alone causes, gives an idea that it is due to respiratory disorder. The common cause of clubbing is bronchiectasis.
Bronchitis.
And in tuberculosis, clubbing is not that common. Remember my word. I always say that common, but it may be present. Suppose if tuberculosis associated with bronchiectasis, it may be present. But clubbing is a very important sign, and you should see like this clubbing. The examiner will ask you, how do you see clubbing? You must ask him, sir, I keep my hand like this and then see it.
Yes, sir.
Carry on.
No resting nystagmus or twin tortosis. No engorged neck vein. No evidence of xanthoma.
What is pallor?
Um,
It's a
sir,
sign of anemia.
yes, sir.
And what is cyanosis?
The bluish discoloration of mucous membranes.
Even the here also. the limb also. You may get cyanosis in hand also. Okay. What is the fundamental thing about cyanosis? For suppose I tell you, when you say cyanosis, what is the definition of cyanosis? I'll tell you, when more than 5 grams of reduced hemoglobin is there, cyanosis manifests. Suppose somebody has got an anemia less than 5 grams, for example, 3 grams of hemoglobin, cyanosis may not manifest. Is the point?
Yes, sir. Yes, sir. A
So
minimum of 5.
you should have a good more than 5 grams of reduced hemoglobin. Please carry
Yes,
on.
sir. No evidence of infective endocarditis. No neurocutaneous marker. Next slide.
What are the neurocutaneous markers you know of?
Sir, one that it could be neurofibroma, sir, as in neurofibromatosis. Shagreen patches as seen in tuberous sclerosis. Um, then Caffioli spots. Uh, then adenoma sebaceum, sir. Ashleaf macules that can be seen, sir.
Sclerosis, tuberous sclerosis. What is
Yes, sir.
Weber syndrome?
Sir,
Fish
pardon, sir.
Weber syndrome. It is called
Sir, capillary hemangiomas, port wine stain,
whole of face will be
port
angiomatous.
wine stain. Yes, sir.
Why it is important?
Sir, they have a higher risk of developing epileptic disorders along with glaucoma.
That is not important. I tell you. You know, have you ever known about notochord? Notochord
Yes,
is
sir.
so it's they lot in skin and brain develop from one particular tissue.
Ectodermal. Yes, sir. Ectodermal origin.
Ectoderm. It's called neuroectoderm. Therefore,
Yes, sir.
whatever defects in the brain may be reflected in the skin also.
Skin.
So that is the reason that we always see that neurocutaneous markers are associated with brain disorders. I'm
Yes, sir.
reinforcing your thoughts. That's all. Carry on.
Yes, sir. Sure, sir. Next, yeah. Systemic examination. Higher mental functions. Conscious, coherent, cooperative. Well-oriented to time, place, and person. Appearance and behavior appropriate. Emotionally stable. Memory recent, immediate, and remote intact. Intelligence average. Speech output, dysarthria with comprehension, word output, repetition, naming, reading normal, calculation normal, able to identify left and right side of the body.
One
Next
stop.
slide. Yes, yes, sir.
Regarding speech output, I'll tell you
Yes, sir.
there is no dysarthria. Okay, dysarthria is peripheral. The speech disorders can be peripheral, can be central also.
Yes, sir.
I'll tell you a very example. Somebody has got aphthous ulcer. I heard about aphthous ulcer. They are viral
Yes, sir.
ulcer. Sometimes your tongue may be bitten or something. Then also you develop speech disorder. You are not able to pronounce properly.
Yes,
If you,
sir.
if you have myasthenia, myopathy, then also you may have speech disorder. If you have your tongue paralysis, then also you may have a speech disorder. So dysarthria, these are all due to peripheral causes.
Yes, sir.
Central causes, cerebral dysarthria. Okay. Dysarthria is a term we use in difficulty in speaking. Difficulty in pronunciation is called dysarthria.
Yes, sir.
Somebody is not able to bring out speech. It is called dysphasia.
Yes, sir.
Mind dysphasia is different. Dysarthria is different. Dysarthria can be peripheral, it can be central. Okay?
Yes,
Dysphasia,
sir.
mostly central. Mostly central. Okay, right. In examining the speech, what are the important things you have to examine? Number one is speech output. Normal output of speech is 20 words to 40 words per minute. How much of speech normally somebody is speaking? Okay. Suppose I don't speak, I speak very slowly because it should be audible. But normally I speak very fast. Okay. Two is, what is the volume of speech? Third thing is clarity of the speech. Somebody speak very clarity or not. Fourth is meaning of the speech. Mean what he really speak. I keep on speaking something like a lunatic fellow. That is not, that got a speech disorder. That's a speech disorder. That is a cortical speech disorder. 1 minute.
Yes, sir.
That is a cortical speech disorder. Are you there?
Yes, sir.
That's called cortical speech disorder. Suppose, and then the most important thing is what is called prosody. He is a speech parameter by which you assess the speech. For example, I'll tell you an example. There is a sentence called, I sold a black horse. So, I can pronounce it in a different way. I sold a black horse means it is I not Prasant.
Yes, sir. I get it.
I sold a black horse means I didn't give free of cost to Prasant, but I sold my horse to Prasant. I sold a black horse. That means I only sold one black horse. I sold a black horse. That means I didn't sell a white horse. I sold a black horse. I sold a black horse. That means I didn't sell a cow. I sold a horse. Emphasis on words is called prosody. Can you imagine a condition in which this prosody is lost? Suppose I speak like this. I wanted to have it. I keep on talking something like that. Suppose I speak like
the face, yeah.
Parkinson disease.
Oh, yes.
In Parkinson disease, this prosody, it is called Prosdy. Prosody. The prosody is lost in the speech, and very important to examine their speech language. Language is different, speech is different. Speech is output of a language. I can suppose, for example, geographical aphasia is there, you know. Suppose I speak talking in Urdu, you may not understand. Suppose I speak Spanish, you may not understand. So this is called geographical aphasia. So aphasia can be specifically should be in the language in which the patient knows. Clear?
Yes, sir.
These are the examination point you should do it. Carry on.
Sure, sir.
Carry on.
Cranial nerve examination. Olfactory nerve, done using coffee powder and asafoetida. It was present on both the right and left side. Optic nerve.
What is the principle involved in it? What is the principle that what you should not do in the olfactory nerve examination?
Sir, we should not use irritative substances like camphor, ammonia.
Why you should?
Because
not?
it will stimulate the trigeminal nerve, sir.
Exactly, correct. It will not stimulate the olfactory bulbs. It will stimulate the trigeminal nerve. Correct.
Yes, sir. Optic nerve, visual acuity, 3 on 6 in the right and left side. Field of vision, normal on both the right and left side. Color vision, normal on both the right and left side. Pupil, single circular, 2 to 3 millimeters, central on both right and left side. Direct and indirect light reflexes present on both sides. Accommodation reflex present on both sides.
What is the importance? What is the importance of examining the field in this case?
Pardon, sir?
What is the importance of examining field in this case? Field of vision.
Yes, sir. Sir, like there can be a macular sparring in case of.
Macula never comes into the picture at all. In
yes.
Lesion, I tell you frankly, in case
yes,
of anesthesia, if the lesion is a bit posterior and this is due to an occipital lobe involvement or whatever it may be, you get a field defect. Okay, even in
yes, sir.
So that gives a localizing value for it. So field
Yes,
of
sir.
not macula is in your eye. Macula is located bilaterally in the tip of the occipital lobe.
Yes,
Clear?
sir.
In the
Yes,
occipital
sir.
lobe, macula is in the central tip, exactly in the back. Macula is represented there. And if I talk about these ocular pathways, it will take another 2 hours. Carry on.
Yes,
Carry
sir. Next slide. Oculomotor, trochlear, and abducens nerves. Eye movements normal in all directions with no ptosis. Trigeminal nerve. Pain, temperature, and touch sensations over the olfactory, maxillary, and mandibular divisions are
on.
normal.
Eye movements.
Sir, pardon, sir.
How do you examine the eye movements?
Um, Sir, we show our finger on each direction and they
I'll tell
see.
you the importance of examining the eye movements. There are
Yes, sir.
voluntary eye movements, there are reflex eye movements. Voluntary eye
Yes,
movement,
sir.
if you have both your hands in the coat and ask him to look right, look left, look up, look down, and look at the nose. Okay, these are voluntary eye movements. Voluntary eye movements may be lost in higher cortical lesion. But if you show a pencil like this, ask him to follow the pencil, that is a reflex eye movement. Reflex eye movement can be tested by 2 methods. Ask him to follow a pen like this, or you can turn the head to either side, and then there is an oculocephalic reflex, So if you turn the head to the one side, your eye will deviate to the other side. So in an unconscious patient, you should try to turn the head, and before that, most often traumatic patients, you must see that there is no cervical injury before examining this test. We will be damaging the cervical cord by doing this this oculocephalic movement. So ensure there is no cervical injury, then turn the head to either side and then see whether reflex eye movements are present. The reflex eye movement can be showing a pen like this, ask him to look up and look down. Okay.
Yes, sir.
Voluntary. So voluntary eye movements, number one. Second is reflex eye movement. They are very important. Trigeminal now.
Yes, sir.
Trigeminal.
Pain, temperature, and touch sensations over the olfactory, maxillary, and mandibular divisions are normal. Sensory, motor, and reflexes conjunctival. Yes, sir.
This is the nucleus of pain and temperature for the face.
Um, Sir, it's the anterior. It's the spinothalamic tract. So nucleus cuneatus.
It is a descending tract of trigeminal nerve in the medulla, descending tract of trigeminal nerve. Trigeminal nerve has got two nucleus. One is motor nucleus, another is sensory nucleus. The sensory
Yes, sir.
is the descending tract of trigeminal nerve. Okay, so
Yes, sir.
why it's important? Somebody may have a motor function normal, but they may have a pain and temperature involvement. Somebody may have only pain and temperature involvement. Motor must be normal. So you get confused because both are
Yes, sir.
locations. Motor nucleus is in the upper pons, but sensory
Yes,
nucleus
sir.
lower pons down. Okay, it is
Yes,
ipsilateral.
sir.
It is ipsilateral. Remember, it is ipsilateral. Carry on.
Sure. Jaw jerk, normal. Next slide.
What is the importance of jaw jerk?
Uh, Sir, the fifth cranial nerve, afferent and efferent.
Tell you, it is suppose if somebody has got a mid pons lesion,
Yes,
mid
sir.
pons lesion, jaw jerk is exaggerated. So
Upper motor neuron and lower motor neuron lesions can be localized.
you open slightly, not fully, all or not like that, slightly, and then tap the chin. Clear?
Yes, sir.
Lesion, sometimes it is lost, sometimes it is exaggerated depending on the location. Normally, in upper motor neuron lesion, jaw jerk is not very useful. No other go. Carry on.
Yes, sir. Next slide. Facial nerve, motor, on raising eyebrows, symmetrical wrinkling seen on forehead, able to close eyes against resistance, Bell's phenomenon not seen, nasolabial fold obliterated on the left side, deviation of angle of mouth to right side. Inflation test, R escape, yes sir.
Question asked the examiner: how do you differentiate an upper motor neuron facial nerve from lower motor neuron? Tell me the differences if you know it. Otherwise, I'll tell you.
So one being that closure of eyes, sir. In upper motor neuron lesion, the patient will be able to close the eyes, while in lower motor neuron, they'll not be able to close. Um, then Bell's phenomenon, sir. Bell's phenomenon will be absent in
I want a
upper
correction.
in
I need a correction. It will not be. He will not be able to squeeze the eyes. Okay, you ask him to close the eyes, not squeeze the eye. He may
yes
not
sir,
be able to squeeze the eye. Okay, right.
yes
Instead
sir.
of that, what will happen in lower motor neuron lesion?
Uh, he'll not be able to like close.
No, it is called Bell's phenomenon. Heard about Bell's phenomenon? What
Yes
is it?
sir. If when like when a normal person tries to close the eyes, the eyeball will go towards the upper and outer quadrant.
Positive in lower motor neuron lesion. It is not positive in upper motor neuron lesion. Now, what about the forehead?
Wrinkling of forehead will be seen, sir.
No, forehead will be normal in upper motor neuron lesion. I'll tell you why. But in lower motor neuron lesion, the wrinkling is absent on the forehead on the ipsilateral side. Clear?
Yes, sir.
Upper motor neuron face is innervated bilaterally.
The lower half is innervated.
It will not be very clearly visible or it will not be affected in cases of upper motor neuron. But in lower motor neuron lesion, there will be definite affection of the wrinkles of the forehead, number one. Second is Bell's phenomenon. Third,
Um,
emotional movements are present in upper motor neuron lesion. Suppose you ask a joke or you say suddenly there will be pain. Suddenly the
yes,
lower
sir.
motor neuron lesion may function, but in upper motor neuron lesion, emotional movements are totally absent. Epiphora, what is epiphora? Drooling of,
Increased hearing.
no, drooling of tears.
Yes, sir.
Increased.
Increased hearing.
Drooling of tears will be present in case of lower motor neuron lesion because the punctum is everted. There is no nasopharyngeal lacrimal duct secretion. Therefore, punctum will be everted. There will be drooling, which is
Yes, sir.
absent in upper motor neuron lesion. Okay. So this
Sure,
question,
sir.
100% every examiner will ask you what is the difference between upper motor neuron lesion and lower motor neuron lesion. So remember and then they will ask you what is the innervation of upper motor neuron in the face. They say that upper half is innervated bilaterally, lower half is not innervated bilaterally. They will be happy. That's all.
Yes,
Okay.
sir.
So this is a different question in undergraduates.
Sure, sir.
Okay. Carry on.
Special sensory. Anterior two-thirds of tongue stays normal on both right and left side. Next slide.
What is the innervation of tongue?
Uh, Sir, the anterior two-thirds is supplied by the cauda tympani branch of facial nerve, sir.
Like,
And,
wait,
posterior one. Yes,
no,
sir.
wait a minute. It is special sense or ordinary sense?
Sir, special.
You are talking about special sense. Taste. Taste.
Special taste, sir. Yes, sir.
You are right. Taste. Taste is
Yes,
supplied by
sir.
many of anterior two-thirds. And posterior one-third is supplied by
Uh, Sir, glossopharyngeal nerve.
glossopharyngeal nerve. Glossopharyngeal nerve. Okay.
Yes,
There is
sir.
foramen cecum, Foramen cecum.
Yes, sir.
The region behind foramen cecum is posterior. One is anterior. Clear? Right.
Yes, sir.
But normal sensation is supplied by lingual nerve.
Yes, sir.
Normal sensation are supplied by lingual nerve. Normally, sweet is placed anteriorly. Bitter is tasted posteriorly. Salty taste is on the both lateral side. So these are the localization of the taste buds.
Yes,
And
sir.
most often lower motor neuron lesion are unilateral, but bilateral lesion often also say that. But very, and then important thing is you should not use solution.
Yes, sir.
Some examiners may say use solution, drop, because when you want to use a solution, some examiners will say, you ask him to open the mouth and then put a drop of salt solution or a drop of sweet solution. You should not ask him to speak, because some of the receptors may be stimulated in trigeminal and give a taste to you. So you must ask him to write whether it is sweet or sugar. Don't ask him to, yes is sweet or sugar. So SW for sweet, SU for sugar. You should not ask him to speak and tell him to tell the taste. These are the common things they will insist on you. Carry on.
Reflexes, conjunctival and corneal, present on both right and left side. Next slide. Vestibulocochlear nerve, Rinne, air conduction greater than bone conduction on both right and left side. Weber, not lateralized to either side. Schwabach, same as examiner. Absolute bone conduction test, same as examiner. Next slide.
I will not worry you about Rene. Leave it.
Glossopharyngeal nerve and vagus. On inspection, the palatal arch is symmetrical with uvula and midline. Gag reflex is normal. Palatal reflex normal with uvula in midline. Air doesn't escape through the nose on holding air within sheaths. Next slide. Spinal accessory nerve. On examining the sternocleidomastoid individually and together, power normal.
What is
Trapezius could,
the action of sternomastoid?
uh, sir, turning the neck towards either sides.
Wow, you are very careful. I'll give the correct answer. If right sternomastoid contracts, it pulls the head to the same side and turns the face to the opposite side.
Torticollis like.
No, don't say torticollis. This is another wrong terminology. You should not use it like that. It is turning the head to the opposite side. So
Yes, sir.
unilateral like this, and then turning the head to the opposite side. So right sternomastoid, pull the head to the same side, and then depresses the head to the same side and turn the face to the opposite side. So the left sternomastoid is opposite action. Okay.
Sure, sir.
Very important anatomical relation they will ask you.
Yes, sir. Hypoglossal nerve, inspection, no wasting, no fibrillation, power normal. Hypoglossal nerve, on inspection, tongue shape is normal and symmetric, no
Wait.
fibrillation.
What is the difference between fasciculation and fibrillation?
Sir, fasciculation are irregular twitches over the skin due to repetitive action of the underlying muscles, sir. In fibrillation, there will be a continuous action of the muscle, while in fasciculation, it will be repetitive and alternate, sir.
No, I will tell you the correct answer. Fasciculation are the contractions of group of muscles. Okay, you see in bundles.
Yes,
You see in bundles. But fibrillations are like waves, It is like a wave. And the important thing in examining this particular thing in the tongue is you should not ask him to pull the tongue out. You must ask him to open the mouth, keep the tongue in the proper position, put a torchlight and examine it. If you allow him to push his head, tongue out, there may be a false fasciculation. False fasciculation. The trick of the examination is never allow the tongue to push it outside. Keep the tongue inside the teeth, then put the torchlight in a tangential way. In a tangential way, it's very important. Because if you put straight like this, you may not be able to see. But if you put it in a tangential way, you'll be able to see fasciculations or fibrillations. Fibrillations are most often not visible, but fasciculations are widely visible. So fasciculations are group and fibrillation is individual muscle degeneration, whereas fasciculations are groups of muscle degeneration. This is
Sure,
the
sir.
okay, right.
On on palpation, normal. Able to push against cheek with the tongue against external resistance. On protrusion, tongue does not deviate. Next slide. Motor system examination with nutrition. Arm circumference 18 centimeters on the right side and 17 centimeters on the left. Forearm 13 centimeters on the right and 13 centimeters on the left. Thigh 31 centimeters on the right and 30 centimeters on the left. Calf 23 centimeters on the right and 23 centimeters on the left, with the impression that there is no atrophy noted bilaterally. Next slide.
Prasad, four
Yes,
ambulances.
sir. Sir,
Four,
pardon, sir.
four ambulances are going across it. Ambulances, four ambulances so far. Carry on.
Yes, sir. Next slide.
I'm not spending time on this nutrition because that's
Yes, sir.
lower motor neuron lesion. We will do it on another day when we deal with the lower motor neuron. Carry on.
Yes, sir. The motor system with tone of muscles. Upper limb, right side normal, left side increased. Lower limb, right side normal, left side increased. Next slide.
Can I tell you something on the development of tone?
Yes, sir. Sure.
Tone is increased. How does normal tone is maintained is there are in the muscle, there are extrafusal fibers and intrafusal fibers. I hope you know what is extrafusal fibers or muscle fibers which are contracting. Intrafusal fibers, and they are called gamma innervated fibers, and there are two types. One is muscle spindle, another is called tendon organ of Golgi. The muscle,
Golgi tendon reflex.
the muscle spindle is very important for us in maintaining the tone. The muscle spindles are innervated from gamma fibers from the spinal cord. The gamma fibers are stimulated by reticular ascending reticular system down regulation. So gamma fibers keep constantly firing the intrafusal fibers of the muscle spindle, and once the intrafusal fibers of the muscle spindles are stimulated, it spins impulses to the extrafusal fibers, keep normally every muscle on a lowest level of tone, even if you take rest, even during sleeping, even during sleeping, these muscles are kept in proper tone. That is lowest level of tone. Right? Okay. When,
Yes, sir.
very basic, I'll tell you, very basic. So in upper motor neuron lesion, both pyramidal and extrapyramidal controls the reticular system. There is a system called ascending reticular activating system. Like that, there is
Yes,
a
sir.
descending reticular activating system. So the descending reticular activating system are controlled by cortex and also by pyramidal system, extrapyramidal. So extrapyramidal and pyramidal controls the down regulation of the reticular system, and the reticular system innervates the gamma efferent in the spinal cord, and gamma efferent stimulates the intrafusal fibers. Intrafusal fibers in turn controls the muscle fiber and creates the tone. Okay.
Yes, sir.
Normally, in upper motor neuron, there is no control of the cortex. So what happens? The descending reticular system becomes more powerful, and they try to put lot of impulses down to the gamma or gamma neurons in the spinal cord. And gamma neurons are overstimulated, and this overstimulation causes overstimulation of the intrafusal fibers, and then intrafusal fibers in turn contracts the muscle more. So this is how you get hypertonia in hemiplegia.
Yes,
Clear?
sir. Yes, sir.
Carry on.
Next slide. Power motor system examination. Upper limb, shoulder, flexion, extension, abduction, adduction, and rotation.
Flip
So I
this.
want 5 on the right.
No,
Yeah?
we'll flip this slide and go to the next one.
Yes, sir.
Next one, next
Next
one.
slide. Again, power. So next slide.
Next one.
Reflexes. Superficial reflex.
What is Hoffman?
Conjunctival cord.
What is Hoffman reflex?
Sir, when the distal phalanx of the middle finger is flexed, there is a flexion of the thumb as well, sir. This is positive in case of upper motor neuron lesion and negative in normal individuals, sir.
Again, it is absent.
Sir, it's positive.
Yeah.
It's positive in an upper motor neuron lesion, sir. Absent in normal individuals.
Chromatic and all very vague. Yeah. Abdominal, again, I have to talk for 1 hour how this abdominal reflex is lost. Carry on. Plantar, very important. It is called baby reflex. The
Yes, sir.
is very complicated, and I think I require 2 hours to discuss about Babinski. So let us skip it. Babinski
Sure,
is always positive in the important thing in Babinski. You must lateral part.
Pardon, sir?
You must give gentle pressure, preferably a pencil or a knee hammer head like this. Are
Yes,
you
sir.
knee hammer?
Yes, sir. Yes, sir.
Soft, blunt, not a sharp thing. You should
Yes,
not
sir.
use a sharp thing to create an incision in the foot.
Yes, sir.
Very blunt, and the stroke should be very slow. It should be upgoing, and important point is you should not reach the ball of the big toe. You
Yes,
should
sir.
not reach. Before that, there should be an extension. Okay.
Yes,
The
sir.
methods of eliciting this Babinski is, one is stroking the foot. Number one is what is called Bing sign. That is dorsum of the feet. If you just prick with a pin, that will
Yes,
go
sir.
extension. Squeezing the tendo Achilles will cause extension. So,
Shaddock and open hem.
yeah, along the shin of the tibia, if you compress, there will be extension. These are the various methods of eliciting the Babinski sign. There are many
Yes, sir.
methods, but these are sufficient for undergraduates.
Yes, sir. Deep reflexes. Sir, shall I continue, sir?
Please. All
The
are,
jaw jerk.
all are exaggerated. All are
Yes, sir. Yes, sir.
exaggerated.
Next slide.
Again, a postgraduate level of discussion is, I will ask the postgraduate why they are exaggerated, but I will not ask you.
Sure, sir. Coordination. On the right side, on the upper and lower limbs, they are normal, while on the left, it could not be tested because of meager power. Involuntary movements, none. Next slide.
Coordination, most often you give importance to the cerebral lesion.
Yes, sir.
This is the right way of expressing it. And what are the abnormal movements you can see in a cortical lesion?
Uh,
Focal fits. Suddenly, they may throw some focal fits, So they
yes,
are
sir.
important. System examination. Come on, carry on.
Sensory examination. The spinothalamic sensations such as pain, temperature, deep touch, and pressure are intact on both the sides. Posterior column sensations such as fine touch, vibration, and joint sense are intact on both sides. The cortical sensations such as tactile localization, 2-point discrimination, stereognosis, and graphesthesia are intact on both sides. Next slide.
What is 2-point discrimination?
Sir, the ability of the individual to localize two different points as two distinct points is 2-point discrimination, sir. Like it is 1 millimeter in the lip.
Tell me. What are the parameters? 1 millimeter in the lips, then?
Yes, sir, 1 millimeter in the lips, and then I think 2 millimeters in the.
At least 5 centimeters in the abdomen and limbs, and the tip of the fingers, it is again 2 millimeter.
Yes,
Okay.
sir.
Lip is very sensitive. You know why I'm telling you. Carry on.
Cerebral function test, finger nose test, finger nose finger test, heel shin test. Rapid alternating movements were normal. On the right side, uh, titubation absent, nystagmus absent, scanning speech absent, dysmetria or fast pointing absent, intentional tremor absent, rebound phenomenon absent, pendular knee jerk absent. Impression that there is no sign of cerebral dysfunction present.
Suppose
Autonomic nervous system, yes sir.
postural
Postural hype,
be tested.
yes sir.
What is the method
Uh,
by you have to do it? You have to do it. What is the method in hemiplegia? Suppose somebody is not able to raise up or stand up to test the postural hypotension. What is the method by which you have to? Suppose I am your chief, I come and say, no, 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 do it. I want it. What is the method by which you can do it? Very simple.
uh,
Tilt the cart. Okay,
okay sir.
tilt the cart
Okay sir.
and then ask him to put the legs down. Clear. Make
Yes
him
sir. Yes sir.
somebody and then measure the blood pressure. Okay, right.
Yes sir.
Can you tell some other simple method by which you can measure the autonomic nervous system? Ask him to take a deep inspiration. If there is a sinus arrhythmia, that means autonomic system is normal. Clear? If you
Yes
ask him
sir.
Valsalva's maneuver,
Tachycardia.
if you ask him to do a Valsalva's maneuver, that will be bradycardia. There are simple
Yes
methods.
sir.
Fine. Carry on.
Signs of meningeal irritation. No neck stiffness. Kernig's and Brudzinski sign negative. Examination of skull and spine normal. Auscultation of the neck and over the skull. No bruit heard over the supraclavicular fossa. No bruit over the skull. No carotid thrill or bruit. Stance and gait. Patient unable to stand or walk on his own without support. Next slide.
Which
Cardiovascular system. Yes,
carotid
sir.
examine? In this
Sir,
case,
pardon, sir.
in this case of left dysfunction, which
Yes,
carotid
sir.
use it? We will give importance.
Sir, the left carotid,
You are in the trap
right,
now. You are in the trap now. You should
right
examine
carotid.
it, you know. You get the point. You are in the trap. So this is a small traps they will ask you. Okay. You should examine
Yes,
the right
sir.
carotid more carefully than the left carotid because the left hemisphere, no? Please.
Yes, sir. Yes, sir. Cardiovascular system examination. S1, S2 heard normally in all areas. Normal S2 split. No added sounds or murmurs. Respiratory system examination. Chest movements equal bilaterally. Normal vesicular breath sounds heard with no added sounds. For abdomen examination. Soft, non-tender abdomen with no palpable organomegaly. Next slide. Provisional diagnosis. Functional, acute cerebrovascular disease with left-sided complete hemiplegia and left upper motor neuron 7th cranial nerve palsy and no associated complications. Anatomical, probably posterior limb and genu of the right internal capsule involving the corticobulbar tract, supplied by a lenticulostriate branch of knee. Yes, sir.
Corticospinal tract.
So,
Cortico
pardon, sir. Yes, sir. Sure. Etiology, probably thromboembolic, likely due to hypertension. The National Institute of Health stroke scale shows 9, moderate to severe. Barthel index of 65, moderately dependent. Next slide.
No, wait a minute. Wait a minute.
Yes, sir.
They will ask you a question like this. They will ask
Yes,
you
sir.
the internal capsule.
Sir, pardon, sir.
They will commonly ask you about the anatomy of the internal capsule. What is the anatomy of the internal capsule?
Uh, there is an anterior limb, sir, genu, and then there is a posterior limb.
So anterior limb consists of what? They are cutting more frontal projection because you may not know it. I am telling you, frontal
Yes,
projection.
sir.
And the genu consists of mostly frontal and parietal sensory. And posterior limb consists of motor fibers coming from the frontal lobe and mainly posterior limb. Okay. The second
Yes,
question
sir.
is, what is the blood supply of the capsule? Any idea?
Sir, middle cerebral artery supplies the posterior limb genu, sir.
No, no, no. I'll tell you. I'll tell you a very easy remembrance. The
Yes, sir.
top portion of the entire, you take it as a block. It is
Yes,
like a,
sir.
it's like a boomerang. It's like a boomerang. So the upper portion of the brick, upper portion of the brick is supplied by lenticular branch of lenticulostriate artery of middle cerebral. Clear? Now
Yes,
you
sir.
divide the lower half of the internal capsule. The lower half, the anterior third, is supplied by antecerebral artery.
Yes, sir.
Middle one is supplied by Charcot branch. Heard about Charcot branch?
Yes, sir.
Posterior limb is supplied by anterior choroidal artery. A, B, C. You remember like that. Antecerebral, basal arteries, and then by anterior choroidal arteries.
And
Anterior choroidal artery. Actually, the posterior limb is supplied by a branch of posterior cerebral. It's called anterior choroidal artery. Okay. Bit
yes,
complicated.
sir.
Try to remember it. Okay, right. Carry on. So they will definitely ask about structure of internal capsule in the undergraduate level and blood supply. Remember that.
Sure, sir. Yes, sir. Investigations. First, with a capillary blood glucose to rule out hypoglycemia, followed by complete blood count, renal function test, HbA1c, coagulation profile, lipid profile, ECG.
This
Yes,
is
sir.
clinical discussion. Let us not go for that.
Yes,
Clinical,
sir.
clinical discussion. Now, what do you think is the condition is? You have said that you go back to the slides of the one which you told, that is anatomical.
One
Now,
slide. Yes, sir.
so now the lesion is clinical diagnosis. It is hemiplegia, number one. And hemiplegia, I think any diagnosis should be a functional diagnosis, an anatomical diagnosis, an etiological diagnosis, and also prognostic diagnosis. Okay, these are the things which are very important. And localization is very important. Localization of the lesion is very important. Now, we have mentioned very clearly that it is acute cerebral vascular disease, number one. We understand the etiology. And it is typically, where is the acute cerebral vascular disease? That you have missed. That is, it should be on the right internal capsule. That is anatomical level.
Yes,
Right?
sir.
Yeah, that you have
Yes,
put
sir.
second point. Okay. Second point. And third is whether it is partial or incomplete. Upper limb is involved more or lower limb is involved more is very important. Now, upper limb and lower limb are involved in the same manner. Cerebral, important thing is no, I am not able to see that. I think you have written it. No cranial nerve paralysis. I think that is hidden here.
Sir, and left upper motor neuron, seventh cranial nerve palsy with no associated complication.
Okay, that is you have written it. Okay, okay. No associated complication. Yes. So this is what they will ask you in the examination. Now you have completed your diagnosis clinically. Okay, right. Now they will ask you what is the management. Then we'll
Um, so,
talk about investigation. Now we'll go to the investigation. What are the various investigation necessary? We'll go to that point now.
yes, sir. Next slide. Investigations. First, capillary blood glucose when the patient arrives so as to rule out hypoglycemia, and ECG is also taken to rule out cardiac causes. Complete blood count, renal function test, HbA1c, coagulation profile, and lipid profile for later management. When the patient is suspected to be a case of stroke, neuroimaging with plain CT can be done if it is more than 6 to 12 hours. But the best would be a diffusion weighted MRI of the brain to uh, to localize the infarct um, and to plan for further management. A transthoracic echocardiography can be done later to look up if there is any nidus in the heart which is a source of emboli.
Much more important, MRA. MRA. That is MRA. Angiography is very important. Okay. Magnetic resonance angiography.
Yes, sir.
That is important because you see the occlusion of the artery there.
Yes, sir.
CT brain normally we do because I don't know the subsequent slides comes in there, but right now I tell you, suppose somebody has got a stroke. We want to treat the stroke immediately. So there is a window period of 9 hours now. Previously it was 3 hours. And those people who are below the age of 70 or 75 now, and we can induce thrombolysis for them and make the brain active again. This is possible only in an MR if there is no, I mean, I'll come back to that. Now, what is you said, what are the various causes of the stroke? One is, you said, mostly thromboembolic, or embolic, or hemorrhagic, or it is thrombotic. This looks more like a thrombotic stroke. Your presentation looks like more of thrombotic stroke.
Yes, sir.
Characteristic feature of a thrombotic stroke is
wake up stroke and
so early morning strokes. Early morning strokes are mostly thrombotic strokes. Embolic are one as you keep speaking something and suddenly you feel giddy and you want to have it, sudden embolus coming in. Embolus is blowing.
Yes, sir.
Very blowing, but they are blowing and suddenly you go for a paralysis. Hemorrhagic is bursting. Mostly they are accompanied with severe, intense headache. Headache is like putting a hammer on the head, you know. It is something very serious and somebody has got a very serious headache and then afterwards they become hemiplegic or something. It is most likely hemorrhagic stroke. Hemorrhagic strokes are common in most of the trauma, number one. Number two, burst of aneurysms in the brain and even burst of small vessels in the brain, they go for a hemorrhagic stroke. So clinically differentiating these three important things. And now when you say it is thrombotic stroke, the first investigation is CT brain to rule out hemorrhage. Once you rule out hemorrhage, you go for MRI and you want to see that which vessel is blocked and what is the nature of the block. And suppose if middle cerebral artery is blocked straight away, you can't do anything. Thrombolysis is not possible. Suppose if there is a small vessel block like a reticular striate branch or small branches are blocked, this thrombolysis is very effective. So in view of the management, we should do all this investigation. Yeah. Next.
Yes, sir.
Next.
The management. In this case, since the patient has come after 4 days, there is no question of thrombolysis. So rehabilitation and physiotherapy with frequent change of position. Antiplatelet therapy can be instituted with aspirin 150 mg once a day. Statin therapy with atorvastatin 10 mg once a day can be done. There is no role of anticoagulant in this case. So if there is a cerebral edema that accompanies in the patient, then a mannitol infusion along with IV furosemide can be given. Adequate BP control with less than 160/90 can be done. Then we can also evaluate for end organ damage since the patient is a hypertensive.
Wait a minute.
Yes, sir.
Suppose if somebody is very sensitive for aspirin, they can't tolerate aspirin, severe gastritis comes. What is the alternative drug will you give? Called clopidogrel.
Clopidogrel.
75 milligram OD.
Clopidogrel, sir.
Nowadays, the combination of clopidogrel with atorvastatin and rosuvastatin has come. It is very good. Okay. How do you know the patient is going in for a cerebral edema? What are the clinical signs of cerebral edema? Loss of consciousness, progressive loss of consciousness.
Neck rigidity.
Signs of coning.
Sir, pardon, sir?
Coning. Signs of coning.
Yes, sir. Like increased intracranial edema, so vomiting and herniation, signs of herniation.
Herniation. That's what I'm telling, coning. Herniation.
Yes, sir.
Suppose if a patient develops early 6-nerve paralysis, you must immediately understand that the patient is going in for coding. Okay, so these are the
Yes, sir.
and anything else you would like to ask you? Anything you like? So this is clinical symptoms. So what is the general advice I give you is never commit anything in advance in the
Yes,
examination.
sir.
Answer to the question adequately and properly. Unwanted commitment should be avoided. If you commit more and more, they will ask you more and more questions. Okay.
Yes, sir.
Masterly inactivity is very important. At the same time, when the question is asked, you must tell them in detail about that. You must present yourself that you know it, but you should not present that you already know it. Then they will go to the next question, which you don't know it. So they normally they compare the students of opposite side. Suppose somebody has come earlier, they will say you are better than him. So when you answer all the questions, they will go to the higher level of questions like a PG. Then they will give more distinction. So this is the trick of the examination. Okay.
Yes, sir.
I think all the students are benefited.
Definitely, sir. No doubt about it.
So thanks a lot.
More than what someone can even expect, sir. It's been a great session indeed.
Sure. All the
A
best.
very satisfying one, sir.
Very detailed examination. I mean, detailed discussion. We are not able to go to actually nearing 1 hour and 45 minutes is going on.
Yes, sir.
You may be tired also. I am not tired, but you may be tired. So hope the opportunities will recur again. We will
Definitely, sir.
thank the IMA for organizing this particular
We
beneficial.
look forward to more sessions from you, sir.
So wishing everyone the best of luck in the examination. Okay.
Thanks a lot, sir.
Thank you.
Thank you so much, sir. It's been a great session indeed. In
Yep.
fact, we've got to know great pearls of wisdom from your experience.
Good luck. We will thank Kiran also, Mr. Kiran also, for having taken all the trouble in projecting the slides and all. Kiran, are you in the line?
Definitely, sir.
Yeah, sir. Yeah. I'm there, sir.
Thank you. All the best.
Thank you, sir.
Thank you so
Thank
much,
you
sir.
so much, sir.
Thank you.
Ignatius, can you present the word of thanks?